for the introduction. It was nice that you all created a good weather moment for us from Portland. We felt right at home yesterday. My shoes are still wet, and I understand that tonight it's really going to be fun. They've been warning us about landslides and how to prevent those and erosion. We don't get that up there. Our storms are usually gentler unless it's an ice storm. So it is fun to be here with all of you. Now, I hope today we have a little fun with this talk. And the first thing I want to ask of you, how many people in this room are Native? Okay. How many people were born in California and started today? Okay. And how many people are not on the faculty at UC Berkeley? Wow. We have a lot to talk about, and I'm excited to be here. And I think that the excitement has to do with putting some Indian issues on the map in California. You all can teach me a lot. I try to come in with an understanding of the Native circumstances and history and such here in California. But I bet you I have some things wrong, and I bet you that you're going to tell me what those things are before the day's out or on our email. Now, when we finish up, by the way, Pat and I put our addresses, our emails, and phone number up here on the wall that you cannot see. Believe me, it's there. When we turn the lights on, we'll be able to kind of look at that and get you'll have a contact for us. We want to hear about you. I think that the most critical part of the partnership of healthcare with Native communities is the fact that the Natives have to use their voices more than they have in the past. We have to be at the table. We have to have the power to say what we think we need within our communities. And I hope that this lecture can add to that. Now, the first thing I should do is to talk with you a little bit about the One Sky Center. And the One Sky Center is now about 12 years old. We, for a long time, have been trying to find resources to create a center that actually could not only address, assess, and deal with Native health issues, but it would advocate for those issues as well. It would advocate in Congress. It would advocate in the governor's office. It would advocate in the newspapers. It would advocate at the universities. And when we did that, we also felt that it was important to kind of set up, you know, there are a lot of good things happening in healthcare in Indian country. We just don't know about them. We don't write about them. We don't get them published. We don't have the researchers. We don't have the people who can provide the input to help us move our agenda forward in healthcare. And that became an issue because we wanted to study the good programs that American Indian people have developed within their communities to advance those, and other people could learn from them. The other issue was, that's programs for research, but we also had programs of opportunity. We wanted to assist and help with those programs that need further help and support to begin to define directions that might help them with the long-term chronic illnesses that face all Indian communities in the country. We looked for programs of excellence. We developed training, consultation, technical assistance. And if you go to the One Sky Center, and you can Google that, One Sky Center, or oneskycenter.org, and all of our talks, this talk will be online. You can download all of our PowerPoints. You can use all of our papers. Everything is there for the Native community and those people who want to work with Native communities. We realize that we have to branch out because there's simply not enough American Indian healthcare professionals to help our people. We need a partnership with those people who are doing the good work. And frankly, that's why I'm here today, is because this program that I've been invited to speak at is trying to make those partnerships occur. The education part comes with the publications of our research, but it also comes from training packages. We saw that American Indians didn't have any kind of guidelines about how to seek help if their children were suicidal. There were no programs, manuals, or any kind of information about how to get help. And so we've developed those kinds of manuals. We've taken manuals for motivational enhancement therapy and cognitive behavioral therapy, and if you will, Indianized them. We helped communities rewrite those so that they could be used more effectively in Indian country. Then we began to add other issues because tribal leadership and decision making. How does a tribal council who has very little actual experience with healthcare problems, how do they manage when a huge healthcare problem is in front of them? How do they reorganize and restructure their finances and funding to get the healthcare services they need? And so tribal leadership and now mentorship and retention are issues that we work with. Now, before I really get into the talk, I want to share something. Maybe it's a little bit of my political point of view as well, but I believe that healthcare reform in this country helps American Indian and Alaska Native people. It expands the access to healthcare in general. It expands Medicaid. It creates new marketplace. It eliminates discrimination due to pre-existing conditions. That's a big issue in Indian country with the chronic illnesses that we suffer. It reauthorizes the Indian Healthcare Improvement Act, long overdue and an absolute essential item for improving healthcare maintenance for Indian people. And then workforce diversity and data collection are also important to be able to talk about who we are. So that's my political statement about health reform. But now I guess I need to share with you two definitions that I use. One is about indigenous knowledge. And this might not be something you think about, but everybody in this room comes from your own culture, your own background, your own beliefs in what works in your health care. Also, how to live your life, how to find people to marry, how to find places to live, how to protect your family. Those are indigenous knowledge issues. Local knowledge unique to a given culture or society. It has its own theory, its own philosophy, and its own scientific and logical validity. It's used as a basis for decision making. Now, when we go one step further and talk about traditional medicine, that's the sum total of all of the health knowledge within a community and all of the theories and beliefs and experiences. It's used to help maintain the health of the people. Now, go with me for a second to an Indian community. It's in a small valley. It's been there for 1,000 years. The people in that valley learned what plants were good for food, what plants were good for medicine, and what plants were good for other animals and even other plants. They also learned what plants not to eat. That's indigenous knowledge. They learned when to plant. They learned about the seasons. They learned about all of the pieces to keep their people healthy. Is that a lot different than what we do today? And so I want to make that point that when we talk about traditional medicine, it's not something exotic. It's something special that we all have. And maybe that's the other thing I want to share with everybody here. I don't believe I can give this lecture just about Indian people and that's it. I think that the lecture applies to all cultures and all people. And the kinds of things that I'm sharing, frankly, are not rocket science, but they're things that maybe we can share with other communities and other populations in this country and in the world. Those definitions I gave you were World Health Organization definitions. Well, the goals for today I have some fun with this. We're going to look at native health circumstances. We're going to explain culture-based interventions. I know a lot of you are interested in that particular area. We're going to explore social determinants of health. Anybody, who's heard of social determinants of health? Okay, so we're going to talk about that, and I'll explain why I think it's a real wonderful entree into Indian health care. We're going to discuss Human Development Index. How many people have heard of that? Much smaller group. I just found out about this last year, and it's one of the most exciting things that I have to share with you today. Then I have a little surprise for you that we're going to talk about. I'll save that for later. And then we're going to talk about mentorship and opportunities, and finally, advocacy and how to get the job done. I believe that medicine, preventive medicine, all health educators, all people working in Indian communities must be advocates. They must know their House of Representatives, congressmen. They must contact, communicate, and share. That's something we must do to make a difference. Well, who are the indigenous people? And again, the World Health Organization says that these people are on the margins of society. They're poorer, they're less educated, they die at a younger age, they're much more likely to commit suicide, and they're generally in worse health than the rest of the population. This definition prompted Michael Marmot, who talked about and developed social determinants, to ask a question about why is it that indigenous people have higher morbidity and mortality. We're going to talk about that. There's 370 million indigenous peoples in 70 countries across the world. That's bigger than the United States population. It's pretty close to it, actually. But it tells me that maybe American Indian people, whom there are 560 federally recognized tribes in this country, that we have a lot to learn from our colleagues around the world. And that's why I think it's important to begin to reach out. Now, I know you've all seen this slide and the famous migration across the land mass and such, and maybe the voyages of the Polynesians in particular, or the pre-Polynesian people. I used the slide to point out something down below. The first migration says from 38,000 years ago to 1,800 years ago. So within 37,000 years, or 36,000, a group of people, multiple peoples, came across and settled into North America and South America. They didn't come together, and they're not all alike. And that's a point I want to make, is that if we're going to study American Indians, be careful not to generalize. You know, the standing joke that I heard years ago was, all Indians are alike, and they march together in single file. At least the one Indian I saw did. You know, it's dangerous to form too many opinions about how Indian people work, live, and are together. If we look at the cultural areas of Native America in 1491, we find out that there was clusters of Native people all over. One of the interesting things to me is that when this country was settled by Europeans and the American people, the issue was that indeed it was a vast empty wasteland with occasional savages. And the justification for the settlement movement and entree into North America really is unjustifiable. When Lewis and Clark came across, they used native trails. They used native horses, actually, from the Spanish of 150 years earlier. They used various kinds of boats that were prepared for them by Native people. And the other thing to remember, you know, if I were to ask you who were the first people to get across this continent, anybody know? Well, not counting the Indians. Mackenzie from Canada. He worked with the Hudson's Bay Company and came across about 8 years ahead of Lewis and Clark. And you know, I point that out because isn't it funny how we learn our history? Isn't it funny how we learn about the people that were here before us, if those people were here? Another way to look at current American Indian country is this map, which is the recent census in 2010. You see areas that are defined as American Indian reservations, but you also see that Indians live off reservation. Now that's a very interesting and quite important observation. We know it happens, and you all have just, well, you'll see about the American Indians here in California on another slide. But here it was interesting because when the Indians move off the reservation, it redefines their relationship with the government. That means that American Indians, in order to get their health and education, have to then transfer and work over with the state government, the county government, and the city government. Now guess what? Some states did not want to do that. There was a Supreme Court decision about this with Arizona, who did not want to provide any resources, that was a federal responsibility. And indeed it was turned around, and we now can get support from states. Another issue for us is the negative stereotypes. I point out especially that football helmet down in the lower right part of the cartoon, that people have different opinions about American Indians and whether we, we're rich. We have casinos. We're getting these marvelous per caps. We're driving big cars. It's really a pretty interesting point of view. I pointed out a little earlier this morning that some people thought that American Indians, I was in a paper I had written, I talked about American Indians and their special relationship with the federal government as being different, and they could not see that it was no different than any other minority population. And if that's your point of view, it's hard for us to get the access to health care redirected and corrected. And so and that person who was making the comment was a very well-known international researcher who didn't have the knowledge to do these things. Well, we've talked about Indian people, and we're sharing, this is a slide that I put together over a year's period of time to show you, Indian people are different from each other. We have different degrees of whatever tribal blood. We have shared tribal blood across tribes. We have shared tribal blood and European, Asian, African bloods. And so talking conceptually about the American Indian, you want to be careful about how you do it. It's very important to remember that we look different. The bottom part of this slide, by the way, those are our two state senators there in the background, and the other people are all the chairs of the 9 tribes of Oregon. And so you can kind of say, oh, okay, they are a little different. They are kind of like the rest of people in the world. Well, now let's talk about California. This is a mission painting of the California missions. And this is pre-contact American Indian, California Indian populations. Very interesting to kind of see this because there's so many changes that have been done here. Most of the tribes lost their lands before the Americans got here. And that has changed the relationships, and certainly the harsh treatment of Indian people, mission people, Rancheria people before is something to recognize. I was able to find this as a American Indian Alaska Native population California is listed as having 710,000 native people. Oklahoma is second with 511,000. Now, I share that. This is an additive number. These are people in the last census that said they were Indian plus something else. So they have two race identity, and when it adds up that way. In fact, if you look at the racial ethnic makeup of California, it is really 162,000 people who identify as uniquely native. Now, by the way, I just said that. I don't believe there's a difference, one, in those two categories. I think that people who identify as Indian who happen to have other blood, if they identify as Indian, they're Indian in my books. And we at least have to conceptually hold that. They might be different in the way they do things. They might have lost their language. They might have lost their quote-unquote understanding of traditional background, but they're native. And we need to look at how to empower and change and help that individual. This is a map I think that it could be an important one for people in California. It shows in blue the higher percentages of American Indian population per county. And so you can then begin to see that the Paiute, Shoshone, the Klamath, the Shasta tribe, the Hupa are, these are areas that we really want to pay attention to because other communities can learn from these more populated communities. But California has a special problem. If you look at the top 10 Indian tribes in California, the top tribes are not from California. That makes it, we talked about this a while ago, that makes the treatment and work with Indian people in California a lot like an urban Indian program in a city. So they have a lot to learn here about how the Friendship House works, or Santa Clara, did I hear? How some of these communities have done their work, because that urban concept would be very, very helpful with Indian people. This is a brief slide to just point out to you that access to health care resources is a disparity issue for Indian people. We get half the money that per capita that people in federal prisons get for health care. Now, our hope is, if you look at that slide, you see Medicaid and Medicare. With health care reform and Indians becoming eligible for Medicaid and Medicare, the hope is that we'll be able to increase the funding and support. I'm going to move over quickly and talk about morbidity and mortality issues. The first is morbidity. You all know, everybody in this room knows this slide. Alcoholism 6 times the general population, tuberculosis 6 times, diabetes 3.5 times, accidents 3 times, poverty, depression, suicide, violence, all elevated in Indian communities. Institute of Medicine, Surgeon General report talks about these disorders and says, Indian people have the same disorders as the general population, but they have much more prevalence, much greater severity, and much less access to treatment. The cultural relevance is profound. That's where we need to touch these problems. An example of disparity in morbidity is this slide that talks about the admission of an Indian person, male or female, over their lifetime for having substance abuse problems. Now, there's some interesting points that I want to make about these slides. First of all, we all can tell alcoholism is elevated. Alcohol use, treatment for alcoholism is elevated in both males and females. If you could walk up and look at this slide closely, I want to point out the slope of that line right there with alcohol and marijuana to the slope of that line right there. Now this is 2009 data. The slopes are similar. American Indian women are starting to initiate drug use for alcohol and other drugs earlier than they ever have before, and they drink and drug a lot like their male counterparts. That's not good news for treatment programs because we're so poorly prepared to treat women in those programs. This could be a funding resource for you, I think, if we look at this as a healthcare possibility. Well, mortality, you see a similar picture. Alcohol-induced or diabetes, we've talked to somebody here who's working with the diabetes program, and homicides, infant deaths, all of these issues are elevated within American Indian communities. An example of that is this slide on alcoholic liver disease. It compares male and female American Indians to other populations. And so you see some biological endpoints here about the health care for Indian people. Again, we go back to Marmot's comment, why is that? Why are we having these problems with our health disparities? His list of those, and the CDC, this is a CDC list, chronic diseases, infant mortality, sexually transmitted diseases, all of these are elevated, and all of these should be much more concerning than they are to the American people. Here's a slide you see a lot of, and I have lots of lectures on suicide and suicide prevention, but I want to share two slides with you. This is a suicide rates of suicide by race. And if you look at this, you find out that the two sides, the two endpoints, the whites and the American Indians, are not that different from each other. You say, well, maybe there's not something here going on. But if you look at suicide among the youth, that's where the difference is. American Indians kill themselves in youth. Whites kill themselves as elders. So there's a very interesting kind of a difference in the way that we do things. I threw in another slide I thought was useful to you, and that's about poverty, because we don't want to miss, after all, I'm here in a social science environment. Poverty is the friend of high morbidity and mortality. And we got that. We got that in a big way. I wanted to give you kind of a list, and you can get these on your, you don't need to go through these, but the reasons for disparities: we have limited access to care. We have poor access to health care insurance. We have insufficient federal funding. We have a quality of care issue. The people giving us care are not as well trained as they should be in isolated communities and other underfunded programs. And then poverty and poor education is hand in hand. So we're halfway done, folks. We've talked about the issues, the problems. I think that it's easy to convince you that we, by the way, there's a Choctaw dance here, by the way, Gil. There's a stomp dance in Oklahoma. And the issues now we need to make a difference, and what kind of philosophic approach should we use? So that's what we're going to talk about the rest of the time, along with that surprise I shared, and along about mentorship. Well, the first thing I thought I should do is to share with you my experience. I've been doing this for a long time. Pat and I have been working in Indian country for 39 years. Over that time, we've learned a lot because we've seen a lot. We've been educated by people who have these struggles. We see lots of different tribes, and that's why we realize when you see one Indian, you have not seen them all. When you've seen one tribe, you haven't seen them all. And if you look at this model, this is a logic model that we're developing. And if you look at it, over on your left, there's something about, oh, well, it used to be on the left. On the left, you can look at this. By the way, I'm noticing that if you put if you put a PC Microsoft slide in an Apple computer, it really does a dance. So would you guys go over there to Stanford and tell them to get this right? Tell them you don't like this. But if you look at best practices and what they mean, and again, Pat and I have talked about how do you look at evidence-based practice, and we're going to try to talk about that just a little bit, because I think evidence-based practice is fine as long as it gets there. The problem is it's not been done in Indian country. The problem is it really is far too narrow. It leaves out so many things, you know, that we need to have. And this one that I want to share with you is culture and the culture values. So the best practice that we used to know was science and scholarship and what was the community standard. That's your GPs applying healthcare out there in the community. That's the community standard. And then you got science. Well, we've got this whole other area called culture values. And when you think about culture values, the philosophies, the belief and such, it starts lining up in an interesting way. You know, I don't have the same beliefs that a community might have about why an illness is there, or how maybe theoretically is the best way to treat it in their understanding. And so what we did is we wanted to look at this and chop it up a little bit. And we decided that we needed to first look at, when I'm called to do a consultation and I hear that there's suicides there, I want to know what their theory is about what's causing it. And I want to know what their theories are about how to care for it. Now that does two things. It puts me on the right track to provide the care because I'm working with them. But it also opens up a whole new avenue of understanding about why this could be a problem. And that's what evidence-based practice leaves out. So the next step is to identify the population that you want to target. Now, you know, I'm a pretty good doc and I think I know how to target things, but I don't know squat when I go out there and work in these communities. And so I need to understand, what do they want to do to change this? More than make it go away. I know they want to make it go away, but exactly who do they want to not have this? Who do they want to have the first steps of care? And then we go about negotiating an intervention. I try to get them to help me write an operations manual so that we can ultimately make this an evidence-based practice. That's why I do that, frankly. These are new ideas and thoughts. How would a sweat lodge be used to treat depression? How would equine therapy be used to help a child who has incredible personality disorder and all kinds of motivational syndrome problems and such? How do we work with those people? And so to really think through, now you all heard of equine therapy, using horses to work with therapy? It's a marvelous way to work, and I've seen some of the best practitioners doing that, and I've been there a bit as an identified patient, and I've ridden horses and I know a little bit about horses, but boy did I learn a lot more. So the other thing is called outcomes, and outcomes means we're not going away. We've got to stay and wait a little while for this to cook up and see how it works. I mean, it's so important that you don't do a consult and walk away. If you do a consult and walk away as a university person, you're nothing more than a researcher who wants to publish in the eyes of the Indian people. You're not there to help them. And we've got to overcome that stigma of us to get that part done right. All right, quickly, I've got to go through this quickly. There's something called key activities in a technology needs assessment. And I've made a list of them here. This is the list when you want to transfer technology into a community. You've got to do a pre-assessment, you've got to determine the focus of the assessment, all of these things. And I went through that and I asked the question, well, okay, what do you need to do in an Indian community? And I put down some other thoughts that I have about how do you get community input? How do you deal with tribal history, both early and recent? How do you align culture into the treatment process? How do you work in partnership? How do you identify a best fit in technology? You know, there's a lot of wonderful technologies out there for providing health care, but we shouldn't just dump it on them and leave. And so we need to kind of let them say, well, I want to try that first. It's okay to use Western medicine in Indian country. It's just an issue of permission giving, reality testing, and how you make things work. Okay, here's the Whitehall Studies, Marmot. Marmot said that within a hierarchical society, there's a social gradient for morbidity and mortality. Okay? What that means is higher status folks live longer and they're healthier. Healthcare improvement needs more than money. It needs opportunity to change, empowerment to change, security, control, and dignity. And as physicians, as researchers, as healthcare providers, as educators, as social scientists, this is our mantra. This is what we need to do to work within a community to actually provide a difference. Now, since this study in Whitehall, there's been a great deal of work in the World Health Organization, but it really points to this interesting diagram that health is surrounded by all of these other things. That you can't help healthcare unless you work with the environment, behavioral, biological, social, cultural, and socioeconomic, and all of the others. All of these have to be a part. Healthcare is not as easy as we thought it was. It's everything. It's the school system, it's the legal system, it's the people surrounding the reservation, it's the stores who don't like Indians, it's racism, it's all of the above. This is the role of the inequalities, and it talks about those issues. And interestingly enough, it says that racism is 15% of the problem, poverty 25%, behavior 20%, genes 3%. Isn't that interesting? Culture 10%. So when you start looking at these things, and here's a study that came out looking at 5 countries, and it looked at mortality in childhood versus wealth in the community or the family. And in all 5 of these communities, in Mali, India, Morocco, Peru, and I don't think that's right, the Russian Republic, all of those areas, the mortality was directly related to the poverty within the communities. It was the strongest predictor. Here's something for Berkeley. SAT scores by income, SAT scores. If you're making money, you get a higher score out of your child. How do you think that makes an Indian feel? Money's not there. What's that child going to do? Those kinds of issues do seem to point out areas where we need to work and areas that we need to address. Fair society, healthy lives. Just this last year, in 2010, A strategic plan for England came about, incredibly idealistic, but I want to share it with you. Give every child the best start in life. Enable all children, young people and adults, to maximize their capabilities. Create fair employment and good work. Ensure healthy standard of living. Create and develop healthy, sustainable lives. And strengthen the role and impact of ill health prevention. Now, that ought to be the Democratic and Republican parties' identity. This is the Bill of Rights for Indian people, and frankly for all people in the nation. And idealistic, yes, so is the Bill of Rights. But shouldn't we understand that we have goals to meet these issues? Human Development Index, I ask you all about, and much less we're aware of this, but it's got some wonderful findings. Human Development Index was developed within the United Nations organization, and it tried to simplify how do you compare populations across the world. And they took 3 issues. They said, we want to measure a long and healthy life, we wanted to look at access to knowledge, and we wanted to look at a decent standard of living. And we were going to work it out, develop a formula, put those together, and we were going to call that the American Human Development Index. That was done at Stanford, by the way. I'm sorry to mention that to you. But indeed, might be good to talk with those folks over there because they have done some interesting work about these issues. Okay, what does that mean to race? They've actually done this study. This was done in 2013. And it's a measure of well-being by race in this country. And if you look in the first box up here, it wants to know about the health index. What's the health status? American Indians are rated the lowest of all of the other cultural groups. That's the circle over there. If you look at education index, we're second lowest. Latinos is the lowest. California's got a problem. If you look at life expectancy in years, African Americans is the lowest, very closely followed by American Indians. And then if you look at the federal median earnings, the ability to have an income, American Indians are the lowest. Isn't that an interesting way to kind of assess where the problems are? These studies have been done internationally, and there's been rankings of all the countries in the world. Norway is first, Iceland is second, Sweden, Australia, Netherlands. United States is 7th. American Indian and Alaska Native is 31st in that list. Canadian Aboriginal is 33rd. Now this slide is incredibly complicated, but it has everything you want to know about California. And it's an analysis of American Indians in this state, and it compares California natives, first of all, to the general population of the United States, which of course they're much lower, but it also compares California with Indians in North Carolina, New Mexico, Michigan, Arizona, all of the top states with Indian populations. Now, this is where you develop your health strategies. Those of you that work within urban programs or even tribal programs, this data is available on a county-by-county basis for the state of California. And some cities are now in the study. San Francisco's in it. I would bet that Oakland is in it, but I don't know that, I haven't seen it. But you can look at all of the issues from life expectancy to education to the index of healthcare, education, and income. And by doing that, you can formulate a way to address the critical problems within your community. And this is active data. This is 2013 data. That's really a marvelous thing to see. How many people have heard of the Wharerātā Declaration? A group of people internationally in First Nations and Aboriginal, Indigenous peoples have been gathering together for the past several years to try to talk about evidence-based practice in a different way. And this is their point of view about it. They've been meeting annually, and it's really led by New Zealand, Hawaii, and Canada. They talk about the need for indigeneity in healthcare decision making. We need to be there. We need to be a part of the decision making. We can't let them keep saying we don't know what we're talking about. We need to know what we're talking about and be there at the table. They want us to think about, instead of evidence-based practice, what they want to say is the best wise practice. Their argument being that the evidence isn't there, but the wiseness of what we take and how we get better is there. And they want us to think about the best wise evidence and indigenous leadership being informed, credible, strategic, connected, and sustainable. How many people here in their Indian tribe has a fight every election time in the community about who the leaders are going to be? We do, and Cherokee are good for that. A good fight's right there. Sometimes we have some of the most interesting political hoedowns that you would ever want to see. And it takes a lot to work through those processes and have leadership who can consistently be there and help over time. That transition process is not good for us. I want to share with you my surprise. I heard about this study in New Zealand that was coordinated with Duke University and the University of London. And it's a study of 1,037 people born in 1 year in a town in New Zealand. And they followed those people semi-annually, basically, over a 32-year period of time. They just collect incredible data, and it's just now opening up. One of the things they studied was childhood self-control. Anybody working in that area here? Childhood self-control is a fascinating area to look at. They did this with marshmallows, and they'd put tasty little things on a table as adults and then get up and leave, and then they'd see what the kids did. Did they have control to leave those marshmallows alone? Now, then they upped the ante and said, did they have control if they were promised something nicer 5 hours later? So they tried to take a good look at control as an issue. And what this study did, they did this study to 3-year-old kids in this 1,037 sample. And they followed them over time, and they looked at outcome. And they found out that childhood self-control, in control, predicted health, wealth, and public safety. You actually could see behavior, positive things about this. And here's the way they did it. They took the top 20 versus the bottom 20% in the sample of high-low, so a high-low split of whether the child had self-control. And they found out that if you looked at 32 years later, criminal records, child raised with single parents, annual income, dependence on drugs, and multiple health problems, that the kids who had self-control did much better. Now, why would I tell you that story? And why would I want to surprise you with it? Well, the interesting fact is that childhood self-control is teachable. You actually can help people improve their self-control. And so you can really consider, gee, can I do something to make a difference with these kids as an early intervention and help? Can I help the parents learn self-control to teach to their kids? Can I help the tribe do that? Can I help the inner city people do that? You know, interesting kind of thing for us to think about. And teaching self-control can be done in lots of ways. I think I put this slide together because I love that guy balancing all those balls and everything. That's self-control part. That guy has got to be the healthiest guy we've ever known. Indeed, it's something that's really important for us to think about. And why would I share that with you? I would share that with you because why don't we do an intervention? Why don't we work with the school systems to insert this within the school and preschool? Why don't we develop this and teach and work with families in a positive way? Aren't you tired of dealing with negative problems in Indian country? Why don't we do some things to focus on the positive? And why don't we see how the outcome would work? Now, you all maybe know theory better than me about whether that's a testable hypothesis or if you're going to live long enough to know. But I think that these are the kinds of studies that need to be done across the world, not just in Indian country. I have two more things to share with you. One is colleges. We don't graduate enough Indians. When we look across the races, we don't do well, but we don't look all that bad compared to the other minorities. You know, those Asians, doggone it, anybody here Asian? You guys got it all. And then we've got these other people that are kind of struggling along. But if you look at it differently, this is the total enrollment in selected health occupations for Indian people. We're not there. We're not in the fields that we're most needed. And so this becomes a critical element when you're trying to help find guidance, leadership, and support. We've looked at mentorship and we've decided to try to make a difference, and we realized that there's no critical mass of Indian faculty at any one major university in this country. And so we put together a faculty of 17 mentors, and they're in the red on this map. And we're working, and we've dedicated ourselves to working with mentees and students who are interested. And we have 30 students who are working with us now. And it's been really very successful to get people, we've had people succeed at writing R01 grants. We've gotten 2 of our mentors promoted to professor. It's really been a remarkable thing. And so this is a virtual university for American Indian healthcare. And we're very excited about that and adding to that pipeline. And so this is a part of where we go and what we do in working. These are leaders of healthcare across the country, the director of the Indian Health Service, the president of the American Medical Association, the president of the American Psychiatric Association, and an international leader in epidemiology research work. And so we're trying to find those people wherever we can find them who are interested in healthcare. And I wanted to share that with you. And a final note that I wanted to share very quickly, I mentioned advocacy. We actually have a bill in Congress that Pat and I put together and have been, it's amazing for a physician to get a bill in Congress, I can tell you that. But if you Google HR 2037, you'll see the bill. We've got, right now, last I saw, we had 22 signed supporters in the House. We're soon to go to the Senate to get more signatures to get this done. It's a bill to increase mental health care and services and training of people into Indian country. And so that's something that we put together, and it falls on the advocacy side that, might not have been in my medical school training to figure out how to do that, but you got to do it. And I hope that you all have as much fun as I've had in my career putting the pieces together. I want to thank you. I know we're a little over time, but I bet you if you stay here and don't leave, we can ask questions and have fun. Thank you very much. And by the way, One Sky Center is a good email. We've got our emails up here and phone number and such. If you want those later, we can get them.
I'll let you just take the questions. We have till 1:30, so.
Wow. Thank you all.